All right, let's get started. So good afternoon, everyone. Thank you for joining us. I'm sure people will continue to trickle in, but we're just excited to have you here with us on this very hot, balmy afternoon in New Haven, Connecticut. I am Lisa Puglisi. I'm an internist and I direct our Transitions Clinic, which is a clinical program focused on the health needs of people leaving incarceration. Here in New Haven, we're part of a national network of similar programs. And I also direct education for our SEICHE Center on Health and Justice. I am delighted to have you here with us today. One of our real goals in our educational work is exposing students to opportunities to conduct research to contribute to the advancement of research that focuses on the health impacts of incarceration for individuals who have been personally impacted, families, and communities most impacted by mass incarceration. In achieving that goal, we have had an array of students working with us all summer, some who could not be here with us today, but who we will acknowledge. And we are here today to really acknowledge all the hard work they've put in this summer for our inaugural student research symposium on incarceration and health. We're excited for you to hear what the group of students has been doing. They're from different universities at different levels of education and training, and their projects that are at different stages in completeness. But this is like a works in progress meeting for you to hear what they've all been up to and to really acknowledge all the work that they've done this summer. Their work has certainly pushed forth knowledge surrounding incarceration and health, from how history can inform not only the COVID pandemic, but also future ones in prisons and jails, to understanding the impacts of incarceration on sleep health and cardiovascular health. Each presentation will last around 7 to 8 minutes, and then there will be time for questions from the audience. So please feel free to chat away and we will address your questions. If we can't get to each one right during the talk, then we will hopefully have time at the end to have some additional questions. This symposium is being recorded. We will post it on our website after if it's something you'd like to refer back to or share with friends and colleagues. We hope there's a lot of students on the line as well who can also spread the word. We will get started in just a minute. I want to acknowledge that Kendall Donaldson and Jaelen King are also students who are undergrads at Yale who worked really hard with us this summer, but were not able to join us today. Without further ado, let's get started. So first up is Amy Du, who is a student at Wesleyan University and will be presenting on understanding the relationship between sleep health and recent incarceration. She was mentored by Dr. Joanna Elam in our lab. And Amy, take it away.
Awesome, thank you. I'm a little bit technically challenged, so this may just take me 1 minute. Okay. Everyone can see, hopefully, my screen. Let me know if it's good. Awesome. Okay, well, thank you everyone for coming. Super excited to be here. My name is Amy, and my project is titled Understanding the Relationship Between Sleep, Health, and Recent Incarceration. All right, so a little bit brief introduction about me. I'm a rising senior at Wesleyan University. I'm a molecular biology and biochemistry and economics student there. And how I got involved, so in freshman year, I actually attended this legislative workshop for reproductive care that was geared toward teaching us about bills that were kind of in the progress of being passed about the treatment of incarcerated women. And I think that got me really thinking deeply about community, about what equity and accessibility really means. And so I got involved with our school's Center for Prison Education, which led me to working at a reentry program in Bridgeport, which led me to finding the Health Justice Lab. So it's kind of this like nice natural progression. And it's been a really awesome experience because I think, there is this community of people around us that are typically kind of left out of the conversation. So I do think it's a really awesome way to not necessarily speak for people, but to amplify the voices of people who may not always be a part of the conversation. All right, so let's jump right in. Starting with a bit of background, why do we want to study sleep? Well, sleep issues are really prevalent in this country. It's a really pervasive issue, whether that's sleep apnea, insomnia, or just chronic sleep deprivation. And we know that this chronic sleep issues puts people at risk, and whether that's hypertension, obesity, diabetes, mental health issues, or in particular cardiovascular disease, sleep is really kind of one of those pillars of health, and poor sleep really influences health outcomes. And so we do know that justice-involved individuals are at high risk for cardiovascular disease, higher risk for cardiovascular disease mortality in particular, but we don't exactly know the driving factors of this. We don't exactly know why. We do know that they've been exposed to uniquely disruptive environments or experiences that could further impair their sleep. So during the time of incarceration, this might be disruptive environments, traumatic experiences or memories. And post-release, this could be housing instability or food insecurity. And there's a general lack of understanding, as you'll see in the literature, about the impact of incarceration on sleep health. And the studies that do exist typically focus on that period of time during incarceration. And so there's really no studies out there that look at the legacy of incarceration on sleep health once people are released. So that brings me to my research question. In justice-involved individuals, how is their sleep health after being released from a correctional facility? And how does their sleep health post-release impact cardiovascular disease risk factor control? All right, so my project is a supplement to the Justice Parent Study. So I'm just going to give a bit of background on what the study is. We're really looking at the driving factors here behind the higher rates of cardiovascular disease mortality in incarcerated individuals. So the study recruits 300 recently released individuals in Connecticut with the goal of identifying population-specific risk factors for CVD in these individuals and how these risk factors change over time, what their impact is, and then use that information to come up with potential interventions. So our supplement is really looking specifically at sleep as a potential mediator of CVD risk factors. Okay, so we take a little bit of a two-pronged approach. First is the scoping review. So here we're really trying to answer the question of, what exists in the literature so far about the relationship between incarceration and sleep health? How have people gone about measuring this relationship? And what interventions have been implemented and have they been effective? The second prong of our approach is just measuring sleep in our participants. And so this is done via baseline surveys. So the Pittsburgh Sleep Quality Index measures sleep quality, the Brief Index of Sleep Control measures sleep control, and the Stop Bank survey measures sleep apnea risk in individuals. And then second, we take a more objective approach to measuring sleep parameters via Fitbit. And so on top of the sleep parameters it measures, it actually also tells us things like heart rate, activity, even GPS, which may be helpful in understanding how something like zip code and location can influence like the variance that we see between our participants. So this is just the participant demographics from the Justice Parent Study of participants that are enrolled so far. I think that it kind of shows some of the challenges of post-release, and you'll see that most of the people are in transitional homes and have little or no income. And so I just wanted to kind of point this out, and it's like a tangible way to see what kind of stressors and things people are dealing with post-release. Okay, so first on the literature review. Right now, we are in the progress of a full text review given our criteria. We've managed to narrow it down to 156 studies, much more manageable than 1852. And so here we're really trying to just see again, like what's in the literature, but what we found so far is that most of the studies that exist are actually international. And again, focus on that period of time during incarceration. And so we do see this general pattern of poor sleep quality and especially insomnia as one of the most prevalent sleep issues. But I think that other sleep problems just aren't really explored, and especially in the United States. So first on the participant surveys, we have the Sleep Quality Index and the Stop Bank survey that measures sleep apnea risk. You'll see on the left that the majority of the participants so far, we only have 22 22. 18 out of the 22 have scores associated with poor sleep quality. So the PSQI is scored 0 to 26, and 0 is like the best quality sleep possible, 26 is the worst quality sleep possible, and 5 is that cutoff. In our stop bank survey, the majority of our participants, 1 are male and 2 are high risk. So 16 out of the 22 of the participants are high risk. And so this survey actually just kind of asks questions. It's not so much scored in the same way on like a numeric scale, but it'll ask about like neck circumference, BMI, like are you male? Has anyone ever observed you snoring? And so I went ahead and calculated the mean PSQI scores for low apnea risk participants and high apnea risk participants. And I think it's just really interesting because you see, the score of 5.75 for low apnea risk participants on average, and 10.5 for individuals with high apnea risk. And so I really think that this does point out this kind of interaction and this connection between sleep apnea or sleep apnea risk, and I think in this case it's measuring obstructive sleep apnea, and sleep health, quality of life in general, and based on studies that have been done, the relationship between sleep apnea and cardiovascular disease. And so I think that this will be an interesting avenue for us to continue to explore down the road when we have more data about, potentially like sleep apnea being a more so undiagnosed problem in this, in our population of individuals. So this is the results for our sleep control survey. And so sleep control is really related to sleep health and health outcomes, even things like stress and anxiety, the perception of sleep. And so this survey is scored on scored 0 to 4, 0 being like the lowest control possible over sleep, and 4 being the highest control. And so you'll see that the majority of the participants fall between some control and low control. And people were more likely to say that they had control over what time they woke up in the morning, but not what time they went to sleep and the quality of their sleep. So we do run into some challenges and questions as we continue to wait for recruitment and to continue our study. And so starting with the scoping review, one of the challenges that we face is that because a lot of the articles that we're extracting from are actually international, we need to take into consideration the differences in kind of the culture, policies, perception of incarceration, and really just kind of acknowledge how that might influence the research and the conclusions that people draw from that research. Second is the challenges in our sleep measurements. We do want to make sure that, the Fitbit is feasible and effective, but I think more importantly than that, we want to make sure that we're acknowledging the comfort of our participants and being conscious of potential discomfort and trauma that they might experience while wearing a device that is trackable 24/7. And so in our protocol, we do specify that participants have the option to turn this off if they choose to. So while the data is limited, I think the data that we do have so far really points to the importance of just understanding and seeing kind of in front of you tangibly the legacy that incarceration has on sleep health, apnea risk, sleep quality, even one's perception of their control over sleep, I think can really exacerbate or add to the challenging and stressful circumstances of having been just released from a correctional facility. And so we definitely want to be able to kind of answer this question so that in the future, we could potentially think of interventions for this group of people. And so for our future directions, I think we're going to continue our full text review of the literature followed by extraction to really paint a fuller picture of what sleep health, quality of life, and I think health in general looks like for this group of people as a whole, both during incarceration as well as after. And of course, because of the pandemic, recruitment has been a little bit slow. And so we are waiting for more individuals to be recruited into the parent study, but as well to funnel into our supplement for the surveys and the Fitbit aspect. And so I want to thank Joanna for her instruction and just making this a really awesome experience, even though, I couldn't go in person, even though I'm 30 minutes away, but, the pandemic has really put some things on hold for us. I want to thank everyone in the Health Justice Lab for the support, the feedback, especially in making this presentation. You guys are really awesome, and I had a really great time working with everyone. And I just want to thank everyone for coming, and I hope that sometime down the road, I'll be able to share more results. All right, questions? Hope I didn't go too over time.
Perfect. Great job. Excellent. Thank you, Amy.
Thank you.
This is a time when, if there are any questions, I don't think I see any in the chat, but just want to open up that opportunity.
How do I go look at the chat? Oh, there it is.
I got it for you, not to worry.
Thanks.
Emily.
Yeah, I have Amy. It's just great work. And, you know, when you and Joanna started this project, I know that one real concern that was raised by our group, by our team, and then also ever-present kind of concerns about supervision and surveillance is this notion that, you know, like they have these Fitbits on, they're being tracked, how they're being monitored. And so just appreciate the attention towards like giving participants the option to shut it down or shut it off if needed. And I wonder if y'all have collected data, and maybe Joanna knows, so, and you don't know, but how many have turned it off?
So from my perspective, oh yeah, we don't have any participants yet. I think it requires a lot of that like face-to-face interaction of going through the protocol. And so unfortunately, I think that's been a little bit like slow given our circumstances.
Yeah, Joanna has written in the text though, that of the 22 that have already collected data and some have gotten the Fitbits, you know, I don't know how many, that no one has turned it off. So I think that that's going to be something interesting too.
I'll add something there, which is interesting, just anecdotally, is that Joanna had shared with me that one participant, or maybe Nadine shared it with me, that one participant actually went out afterwards and bought himself a Fitbit because he so enjoyed sort of having access to his own data, and he found that it helped him engage in his own health and doing certain amount of steps in the day and stuff like that. And so, I mean, that's one, but that's some feedback that they got.
Amy, you have another question here, which is from Katie Clark. She says, sounds like a great project. How's the survey being collected? Is it interview administered? Is it self-administered?
Yeah, Joanna, you can correct me if I'm wrong because I haven't done any of the surveys myself, but I do believe they are interview administered.
Correct.
Awesome.
All right, so I'm going to stop our conversation there, pause it for a little bit. You may get more questions for later, Amy, but thank you so much. Next, we are going to move on to Alex Halberstam, who's a Yale undergrad, and she will be presenting to us on a talk entitled, "It Kind of Makes You Feel Like You're an Animal, a Qualitative Description of the Correctional Response to COVID-19. Alex, take it away.
Can you hear me okay? Yeah, okay. I have a very loud fan in the dorm room, but should be okay. Let me just share my screen very quickly. And get to the beginning. Okay. Okay, and then present. Okay, does that show up okay? Great. Okay, hi everyone. My name is Alex Halberstam, and as Dr. Puglisi said, I'm going to present my summer project, It Kind of Makes You Feel Like an Animal, a qualitative description of the correctional response to COVID. And I wanted to just briefly sort of mention, we already said Jaelen King is not here. He worked with me on the whole project. So I wanted to sort of give the background of both of us, just so you know where we're coming from, and also to acknowledge all the work he did on the project all summer. So I'm studying molecular biology and the history of science, and I'm interested in how history and social policy shapes definitions of health and medical care, and how understanding these factors can support community-based care and health justice initiatives. Jaelen's also an undergraduate, majoring also in molecular biology, and is very involved with community engagement efforts at Yale. He was the Community Engagement Initiatives Director for the Afro-American Cultural Center. And he's interested in thinking about how to alleviate health issues that plague underserved communities. And both of us are student research assistants at the SEICHE Center and are going to be continuing with the center in the fall. So turning to the project, COVID-19 exploded in correctional facilities, as most of you know, and facilities were completely unprepared to prevent the spread due to close contact between incarcerated individuals, a lack of ventilation, inconsistent communication, and just generally poor living conditions that exacerbate COVID spread. And now we're at a moment where infection rates are dropping, routine rooms are resuming to some extent, but fear, particularly among incarcerated individuals, persists. And of course, new surges and new variants also prove that COVID issues are still essential to address and also urgent. And we're at a point where we want to implement immediate improvements in correctional settings, but also think about how to better prepare and respond to future pandemics and kind of about correctional settings in general and all the lessons that this pandemic has brought up. So this project is ongoing, so our research questions are still emerging, but broadly our goal is to understand the experience of COVID-19 in correctional settings. We hope to identify ethical concerns and potential solutions for COVID-19 testing and vaccination strategies. But we also are gathering material that lends itself to a variety of other explorations, including questions of mental health, experiences in treatment in carceral settings, the normalization of solitary confinement, protection of the humanity of incarcerated individuals, and forms of communication and information distribution, and also a variety of other themes that are still emerging, but these are just sort of four of the big ones that we're pulling out. And this project is part of the Radx Up study, which is sort of a larger study divided into two aims. And the first aim seeks to qualitatively study the successes and failures of the correctional response to COVID. And aim two is about the incidence of COVID-19, disease progression and related outcomes, and the effectiveness of testing and contact tracing in correctional settings. And our summer project was situated with aim one, so that's what I'll be talking about for the rest of the talk, but wanted to kind of situate us in this larger project. And our study involves open-ended interviews with incarcerated individuals, correctional leaders and officials, office staff, medical specialists in 4 states at 4 different sites, which include both prisons and jails. And we've done interviews in Rhode Island and Washington already, and hope to conduct more in Florida and Minnesota or other regions that kind of represent different areas of the United States. And our team includes interdisciplinary experts, as well as formerly incarcerated individuals. And whenever possible, the interviews that we're conducting are conducted by the expert with the experience most closely related to the role of the interviewee. So that means that medical specialists or medical experts interview the medical staff, formerly incarcerated individuals interview the currently incarcerated individuals, and so on. And this summer, we've been modifying the code book, coding interviews, and identifying frameworks for analysis. And we're also sort of wanting to talk about two of the big pitfalls that go into our methods, which is that we're double coding each interview to minimize monolithic thought, meaning that we want to have multiple perspectives going into the understanding of every interview. And we're using a flexible and ever-evolving code book. So we're still interviewing and coding, but we're already starting to discover some easy fixes and obvious problems. For instance, don't offer the vaccine at 8 p.m. at night. We're also uncovering broader trends of humanity, trust, and uncertainty. And some of these themes are about information flow, agency over hygiene, normalization of solitary confinement as a form of quarantine, and the relationships and routines that are disrupted by lockdown and quarantine. And so these broader trends kind of fit into those themes from earlier, and this is sort of just explaining kind of the variety of different directions the project can go in. But I did want to talk about 2 of these themes and provide 2 quotes to sort of give you an example of how we're matching quotes to these themes for future analysis. So the first theme is about communication, and this is a quote from an incarcerated individual at Rhode Island who explains, yeah, no reassurance, no update. It's almost like we weren't even worth any of that information because we're like second class. Like, yeah, the hell with you animals. We don't need to tell you anything. And so as she points out, the lack of consistent communication challenges both dignity and humanity of incarcerated individuals, as well as just being completely irresponsible and kind of unclear. And the second thing we wanted to mention is hygiene. And this is also from an incarcerated individual in Rhode Island, explaining how shower access was limited during quarantine. And this is a conversation she had with Jay, a medical specialist at the facility. And she recounts, I looked at one of those nurses and said, Jay, I haven't even showered in 22 days. So he said, you need to put this girl in the shower. That's inhumane. And this also reflects the inhumanity that developed out of fear and really, again, a total lack of information in these facilities. And this also helps elucidate the role of the medical staff in particular in choosing to mitigate or not mitigate these humanity threats and protect the dignity of incarcerated individuals. So it's sort of another like way we think about the relationships that are emerging from multiple perspectives. And we're still connecting quotes with themes, as I mentioned, and identifying additional ideas, but these were two examples of how we match quotes and start thinking about analysis. So we've had quite a few challenges. First, since our codebook developed from interviews, we're continuously refining it, which means we'll need to go back and recode the interviews we did at the beginning before the codebook was sort of more finalized. We also want to ensure that the demographics of the interviewees match the facility, but also want to hear from everyone, especially groups that are typically underrepresented in decision-making in these settings, even if that means that we need to oversample certain groups. We also want to make sure that the interviews remain interesting, which means continuously adjusting questions. And finally, the interviews can be quite emotionally intense for both the interviewee and the interviewer. And we struggle to balance both using the interviews as a space to process experiences that people have had, but also keeping in mind that for incarcerated individuals in particular, they need to return to certain settings, so jails and prisons after the interview ends. So that's some sort of a tension we've really thought about how to mitigate in these conversations. And then looking ahead, we're going to continue coding, refining questions, and analyzing themes. We also hope to find a framework to guide our large overarching questions. This is one example on the right of a framework for thinking about structural inequalities and social determinants of health. And we hope to combine a framework like this with some kind of emergency preparedness, emergency response framework, which will both hopefully enable us to respond to concerns of health justice and structural inequality, but also talk to both an audience of currently and formerly incarcerated individuals, communities, and then also correctional staff and government officials. And that's all I have for right now. Thank you so much for listening. I'd be happy to answer any questions.
Thank you, Alex. Fantastic job. Thank you for taking us through that. And it's a big ongoing project, but you and Jaelen have been so core to it and so immersed in it this summer. I appreciate your summary of the work. Let me open it up to other people's questions. I'll ask you a question, Alex, while we wait for people. What are you learning from this that you're surprised by? You know, some of it is like, yes, that's what we maybe expected to see. You know, hearing it in people's words gives depth that is unimaginable, even to themes that were entirely predictable. But I wonder if there are things that are popping out that you're surprised by, you didn't think you would hear. You've read now tons of words of people, you know, personally impacted. I don't think you mentioned that we're also focusing on correctional officers and correctional leaders to really think through how this whole ecosystem interacts and how maybe sometimes interests are actually quite aligned when it comes to safety, health, and protection. But I wonder what themes are emerging that you're surprised by.
Yeah, I mean, that's a good question. There's sort of kind of big picture stuff that's emerging as well as like little details that have really kind of caught my attention. And I say that the big picture stuff is sort of more that even as these programs develop and there is awareness of the problems, there's these just like really, and this is what I mentioned about like vaccinations at night, just these like really obvious quick fixes that I think are surprising to me, because it sort of wouldn't surprise me, I suppose, if there was sort of a facility that like didn't have a testing program or like wasn't focused on this. But the fact that there is a focus on these sort of both vaccination and testing, and then also these just like really simple fixes that could make a really impactful difference. And then I think sort of the things that interest me personally more are these smaller quotes that really capture kind of the ways in which these ecosystem is the word you've used, but also just these settings work and how people cope with the different challenges of daily life. And then also how those coping mechanisms are completely undermined by the challenges of the pandemic. So one thing that we've talked about in some of our meetings is particularly in prison settings or settings where people are around for longer, these strategies of kind of creating a sort of home or even neighborhood with the physical location within this facility that people have, and then how that's completely disrupted by concepts of relocation, lockdown, quarantine, and sort of just, I think understanding how people are dealing with those challenges is really important to me. because it both sheds light on sort of like general coping mechanisms in these facilities, and also how public health measures can just completely disrupt that. I can give some other examples, but so the little things catch my attention.
Yeah, I think that's really interesting too. Often the term is used like, oh my God, I just lost it, but it's like mobility, like people getting movement and mobility, like people just getting moved around. And it's really kind of sometimes like displacement from a space that was made to feel it was a home, even though, you know, it wasn't a home that maybe people would think of, but that was a home space. And what that sort of does to people. Yeah, that's interesting. I've been particularly surprised by some of the things. I love the stuff around interaction. Like there you had like, often we're heard negative things about correctional health. In the last quote, you heard like a nurse really acknowledging like, yes, this was inhumane. And that's how that person like really got their shower. How do we help so that it doesn't get to 22 days without a shower, you know? But this is not unique to one facility. This is a national, you know, issue. This is what we're hearing in many different facilities. But I think that stuff is really interesting too, especially around employment of correctional officers and how they're impacted by the pandemic as well. Other questions? Let's see.
Alex, there's a bunch in the chat for you. And so one, I'll read it out loud. So one of them is asking you just to restate the title of your presentation. So maybe we'll just type it out for them. But kind of, there's two questions here that I think would be interesting to take on. So one is, what do you hope to see happen as a result of this study? So, you know, like you're thinking about the end game, where do you hope that this will go?
Yeah. I mean, I think that's a question that has two sort of very different answers. First, I'll just say that this quote, the title comes from an interview with someone specifically talking about the lack of information and quarantine lockdowns. Sorry, yeah. So I think there's sort of two separate answers that have to be merged to that question. And one is the fact that like these are things that are happening on the ground immediately. And so there are very immediate short-term solutions that we're really hoping to kind of bring to attention. And that's part of the thinking about the emergency preparedness idea, that we really want to be appealing to officials and government staff that have the ability and the power to sort of implement immediately. So that's things like offering vaccines more regularly, understanding that the fear of quarantine is limiting testing acceptance rates, understanding that information flow needs to be adjusted in these three ways, sort of things like that that are kind of immediate fixes that won't really require structural change. And then also understanding the kind of, which to me is more interesting and sort of more, that I'm more passionate about, are these like sort of long-term sustainable structural solutions to why the cracks that were kind of revealed by the pandemic were obviously there before. And so thinking about ways to move towards things like decarceration, things like population changes, things like much more agency over decision-making in these facilities, and kind of like larger, I mean, that's sort of like a more long-term goal of changing the kind of, I mean, this is something like everyone we think about in our lab all the time, but like the long-term existence of these settings and how we can sort of change them. But yeah, so like sort of those two categories of like, we can't wait for that. People are in facilities and are in trouble right now. And then also thinking about how we can make sure that our immediate solutions are also moving us towards the sort of long-term goals rather than the other direction.
Great, thank you. Lisa, do we have time for another question or should we? Okay,
yes, one more.
And then another question I think, which is always an important one in thinking about corrections, is if there were specific themes that emerged that were gender specific. So you mentioned really trying to make sure that the individuals you're interviewing are representative, and often women are, you know, they're obviously not incarcerated as high of rates or high numbers as those as men. But I wonder if there have been some specific themes that come up for the women you've interviewed, either those that work within corrections or those that are incarcerated.
Yeah, I'm trying to think specifically, and I know there's other people on this call who have also read quite a few of this interview, so if they want to jump in with anything, either in the chat or verbally. I mean, one of the things that we noticed when we were going through the demographics is that we haven't interviewed Black women at the most recent facility. And in part, that does reflect the demographics of the facility, but we also think is unacceptable. So we're sort of hoping to go back and capture that demographic, which is specifically like those perspectives are missing. And if you just did a one-to-one, let's make our interviews reflect the facility, you might miss those perspectives, and that's just not something we're willing to do. So that's kind of what I meant about that topic, which I think also kind of informs my answer to this question, that we're really missing quite a few perspectives. So I'm sort of not prepared to universally speak to that. I do think interactions with, trying to think, I think the interviews I've read are often, there's differences in how many times people have been incarcerated, and the people who have been sort of out and in have different perspectives from those who have sort of spent long periods of time inside. And I think some of those are across gender lines, as well as kind of concern about family and roles. That's a little bit sort of concern about COVID at home and also bringing COVID back. And that's particularly with the correctional officers as well. Although many of the correctional officers have partners who are also in corrections. And so often there's a woman talking about her experience as a correctional official, but her husband is also working in corrections. So I'm not sure sort of, it's not quite a response. But we get sort of parallel opinions, I think sometimes. I'm not sure, does anyone want to add anything to that? Nothing massive is emerging to me right now, I think is what I'm thinking, like not sort of, I know there was one woman who's an older woman and describing like interactions with younger women at the facility, but that wasn't sort of like a specific gendered experience. It just happened to be one of the people we interviewed.
Agree. Great. I'm going to stop us there and move us along. Thank you, Alex, for all your hard work and that great presentation. Okay. Next, we have Carolyn Beit joining us, who is a Yale undergraduate student as well, and will be presenting her talk on the Newgate prison experiment, lessons from England's first vaccine trial for the COVID era. Caroline, take it away.
Yes, can everyone see the presentation and hear me? Okay, so as Dr. Puglisi said, my topic is the Newgate prison trial. And I just wanted to first thank all the amazing mentorship I had this summer, specifically from Dr. Elizabeth Hinton, Michelle Daniel Jones, as well as Alex Halberstam, who really helped me edit my presentation, as well as the rest of the SEICHE community. And first, just a bit about me. So I'm originally from New York. I am currently a junior at Yale College studying history of science and medicine. I'm also on the pre-med track. And I also wanted to explain a bit as to why I'm interested in this work. So I had a couple of experiences in high school that really made me interested in kind of systems of power, specifically incarceration. Firstly, I worked as a tax preparer in high school and learned about the American Opportunity Credit, which those convicted of felony drug convictions are categorically excluded from getting. I had a friend, close friend in high school who had a pen pal who was on death row. And lastly, I went to a Catholic school where we discussed kind of social justice and the ways in which the American prison system is unethical. I also have solidified this kind of interest and understanding through my own research. Specifically, I wrote a paper in 2020 on prison nursery programs. And lastly, as you know, kind of an HSHM student or a student of the history of science and medicine, I'm really interested through understanding impacts on health through the lens of history and wanted a project that combined all of these interests. So a bit of background about my project. First, I'm going to start with a bit of background from today and then move into kind of the history of the Newgate prison experiment. So especially given, you know, the COVID-19 pandemic, more really needs to be done to protect the health of those facing incarceration. And, you know, as we've seen today, you know, COVID-19 has really ravaged prisons, and one potential mitigation strategy is vaccination. And I argue that the Newgate prison experiment can provide a historical example of the involvement of those who are facing incarceration in medical clinical trials. And lastly, you know, currently in the US, because of 45 CFR 46.303C, which is an IRB regulation, as well as the history of unethical experimentation in prisons. Incarcerated people are, effectively categorically excluded from participating in medical clinical trials, which I argue may present some challenges. Next, I want to talk a bit about the history of smallpox and variolation, which is kind of a precursor to vaccination in Britain. So in the 1700s, smallpox was ravaging through Britain. It was very common, and there would be, seasonal and periodic kind of upswings and upticks that would result in epidemics. One of these was also in 1721. And during the Enlightenment period, which was from kind of 1685 to 1815, medical scientific experimentation really took off and, kind of became a part of the sciences. And lastly, variolation, which is a precursor to vaccination, had taken off in Turkey and China, but it still needed to be tested in England before it could be kind of accepted by the population there. So a bit of the history about the Newgate prison trial itself. So Newgate prison was kind of this infamous prison in England. If you actually go to England today and do kind of one of the tours, you can see kind of the remains of the prison itself. And it was a place with really dismal conditions. There's reports from those who were incarcerated, explaining their perspectives, as well as one case where the prison needed to be shut down for a while because it was so noxious that it was infecting people outside of the prison. And, the incarcerated persons so the trial, was set up to basically test this kind of experimentation. And, the incarcerated persons that they chose, who were the only participants, agreed to participate in exchange for receiving a pardon for their participation, as well as, potential immunity from smallpox. The trial went on for about 2 weeks. They were, injected with kind of smallpox pus. And, it showed both the efficacy and the safety of variolation, which again would be a precursor to smallpox vaccination. And it's important to note that, the trial would lead to the adoption of, variolation initially by the upper echelons for society. So it wasn't necessarily an equitable distribution, but eventually it would be available to everyone. And just so you can see on the side here on the right, this is actually an official copy of King George's pardon for the individuals who participated. So all of this information led me to kind of 2 central research questions. The first is, how does the 1721 trial reveal the benefits to both incarcerated persons and the larger community of the use of clinical trials in correctional settings? And secondly, what are some elements of the 1721 Newgate trial that should serve as a model for including those facing incarceration in clinical trial, obviously with proper safeguards, especially during times of pandemic. And, some kind of results of this is that, there were benefits, including, immunity from a very deadly disease, like we're seeing in the COVID-19 world with the benefits of vaccines for those who are incarcerated and not incarcerated. But there were also issues such as kind of a lack of potentially true informed consent, though there were potentially some kind of modern day parallels to informed consent procedures, as well as possibly not explaining all the risks and choosing a sample that only included incarcerated individuals. So, what are some of the methods that I used to kind of arrive here? So I used a lot of archival research and constructed a narrative, which, is hopefully going to be a paper. And I combed through kind of a multitude of sources, including firsthand reports from those, facing incarceration about the conditions of the prison, letters from the king, books and narratives from the time written by, doctors who performed the procedures, as well as, great philosophers like Voltaire and their opinions. I also read a multitude of secondary sources that put much of this primary information into context, as well as, clarified some inconsistencies in the primary literature. I also reached out to various researchers who had done this type of research previously, and contacted my personal librarian for help in kind of doing this massive amount of research. I compared this cross-temporally to what went on in 1721 and what's going on today in the COVID-19 pandemic. And I also really tried to develop bioethically sound recommendations for the inclusion of those facing incarceration, potentially in vaccine clinical trials, both building on the history and what we know today. And I definitely received assistance on this from kind of all the members of the SEICHE community. So what were the results of my research? The trial at Newgate, which was successful from a scientific lens, did have many issues. And this includes the background conditions of the prison, issues around informed consent, and the fact that those facing incarceration were the only test subjects. But there were also some positives, including that the subjects were released from not only their death sentences and the prison, but with some immunity to the dangers of smallpox. And lastly, what I think is really important to remember is that we can't ignore the history of vaccine clinical trials when we're informing the progress of new ones. And some kind of interesting quotes around this is that in the 1700s, people were really aware of some of these issues, including one of the kind of people who pushed for this trial, who realized that smallpox was made harmless by variolation or vaccination. Voltaire, who realized that those facing incarceration were kind of prevented from the dangers of smallpox because of this trial, as well as formerly incarcerated individuals who talked about the horrors of the prison and possible needs for reform. And this kind of led to two major themes, which is that those facing incarceration are a vulnerable population, but that they should not be categorically excluded in all cases from participating in clinical trials, and that real benefits exist to both society and incarcerated persons. And lastly, it's really important to recognize that, proper safeguards for all vaccine clinical trials need to exist and should be, definitely extended to those facing incarceration, especially, if they are to be included in these instances. And, some kind of questions around this is, how does this relate to COVID? Well, I say that it really makes us think about how do we organize clinical trials in this pandemic and future ones? And, what are kind of the implications of these themes? And I argue that the implications are that more research needs to be done to understand why or why not we should potentially include those facing incarceration in vaccine clinical trials. So what are some next steps? Well, working on editing my paper as well as answering your questions. And I just want to thank everyone for your time.
Thank you so much, Caroline. Awesome job. I have a million questions in my mind. I'm going to see what's in the chat. Nothing yet, but as I give people time to enter stuff, I wonder, so this is just such interesting stuff, and you've taught me so much this summer, so I've so enjoyed working with you on this and learning from you as you worked on this. I think though, a lot of things come up for me. And as you know, we're kind of obsessed with thinking about now vaccines and clinical trials in prison. But, I wonder what you think about getting out of like a pardon as the compensation for being in a clinical trial. In some part of me says, well, that's incredible. You get out when you were serving a life sentence. Like, I don't know many people who wouldn't want to do that. And then part of me says, well, that is just really coercive. Like, it is a compensation that is so important and so grand that who's going to say no to that trial? And it just so happened that the vaccination and variolation went well and were effective, but that's not necessarily always the case. In fact, usually clinical trials are negative. So, I wonder what we can learn from that, because I'm hearing so many similarities that may make me think of the clinical research that was done primarily in incarcerated people in the US until the late 70s. And I wonder what you think about that.
Yeah, so I think there's a couple things to consider with that. So I actually serve on one of Yale's IRBs, and we kind of ask this question at a bit of a smaller scale of what is coercive and what's not. And I think it's important to recognize the ways in which clinical trials in general and research in general can be coercive, especially in terms of, offering individuals very large sums of money, offering clinical trials as someone's, kind of only hope. And I think we need to recognize that before necessarily making a declaration on, is release from incarceration, coercive. So, in short, was it coercive? Yes, probably. But in terms of research in general, we see a lot of coercion as well. And where does it fall on that gradient of what is acceptable and what is not? I think that is more important to recognize, because I also think that there's a tendency to say, well, we don't, to be so risk adverse that we actually end up harming people. And because of that, I think it's, kind of really important to balance what are the risks that we're willing to accept in the general population, and why won't we extend those same risks to those facing incarceration. So I think it's definitely, there's a need for a balancing act, but I don't think that we should inherently, shy away from this potential, benefit, especially if it's commensurate with other risks that we're willing to extend to non-incarcerated individuals.
Interesting. Yeah, I think there's not one answer, right? Like, I just love hearing what you learned about it. Did you, what sorts of narratives did you get of people who lived through that, the incarcerated people and previously incarcerated people at that time?
Yeah, so there's kind of a couple of things. So there isn't that much, or there actually isn't anything from the individuals who were actually in the trial. There's no kind of reports from themselves. But if we actually go back, there is a report from someone who was formerly incarcerated in the 1790s, which is about kind of 70 so years after the incarceration or the trial. And Thomas Lloyd talks about how the prison was so filthy that everyone was kind of in the midst of hunger, disease, nakedness, rapine, and finds the means of gorging its voracious maw. So I think that really talks about the kind of hideous conditions of the prison. And there's other reports dating back to the early 1300s that detail the real horrors of the conditions of the prison.
Thank you. I'm acknowledging, so there was one question in the chat that was asked similarly. And Dr. Staples Horn says, what if no incentives are offered? Is that a better indicator of true consent for participation?
I'm going to say that I'm unsure of that, especially because we do offer, incentives for participating in studies to non-incarcerated individuals, right? If I know many Yale undergraduates, for example, who have chosen to participate in sleep studies, to participate in, other, blood draw studies, kind of very invasive testing because they need money. And I don't know, I think consent is a gradient. I don't think consent is kind of a binary. And I think that it's really important to think about the fact that there might be things that are more coercive than others, but that, we rely on a system for research, at least currently, that does involve, having inducements for people to participate in research, at least at the very basis of compensating them for their time.
Great, thank you. And I think we can take one more question.
There's a question in the Q&A. So, Caroline, so it goes, how would you get past the optics and perception and the reality that including incarcerated people in research is a form of experimentation, especially when the population is majority, or in certain circumstances, majority Black and brown, but certainly disproportionately Black and brown?
So I think that there's a couple of things for this. One thing I really disagree with the, Newgate prison experiment is the fact that it only used, incarcerated individuals, which, I don't think should be the case in modern clinical trials. But I also think on the, the flip side of that, there's a need to, you know, we know that we don't want to, we also at the same time don't want to prevent individuals who might benefit from clinical research from participating in it. And, you know, acknowledging that, you know, there is a majority, you know, there is a majority of Black and Brown people who are, you know, in, or the majority of people in US carceral systems, you know, may be Black and Brown. By systematically excluding them, I think we're also doing a disservice. And that's not to say that the brunt of clinical research should, you know, fall on them at all, but that the brunt of excluding them is also very problematic.
Thank you for that, Carolyn. I think I agree with you. I think it's complicated, but I think being systematically across the board in any one direction, either solely in incarcerated people or entirely exclude incarcerated people, misses a lot of the nuance and can lead to inequity as well. Great job. Thank you so much. I'm sure more questions will pop up, and we're going to keep moving to stay on time. We are going to move on to Charlotte Kim, who is with us as a Yale Medical School student. She is going to give her talk to us entitled, How an American Prison Lived Through the 1918 Influenza, Implications for Future Pandemics. Charlotte, all you.
Awesome. Thank you so much, Dr. Puglisi. So as Dr. Puglisi mentioned, I'm a med student. I'm about to start my second year here at Yale. She gave the title of my presentation. So I became interested in prison justice since college when I worked with a local organization of artists who were formerly incarcerated. And so they were using like hip hop, art and dance to sort of rebuild community and to kind of like foster at-risk youth. And academically, I've also just been fascinated by microbiology and by infectious diseases. And it happens to be something that's really pertinent to prison health, given sort of like the overcrowded conditions. So my research is going to focus on the 1918 influenza and the implications for future pandemics. So let's start by reiterating that mass incarceration is a public health crisis. So as you can see here, cases of COVID-19 among the incarcerated population, which is represented by the yellow, just really strikingly outweigh those of the general population in orange. And this is true for just about every state in the United States. And the real tragedy of all this is that pandemics are nothing new. So our team is using history in order to illuminate future lessons on how we can manage pandemics within prisons. And what the novelty that we really want to strive for is centering the perspectives of incarcerated patients themselves, whose voices have historically been ignored or dismissed in history telling. So the influenza of 1918 is really the one illness that has been so eerily similar to COVID. So clinically, it was also spread by air, which meant that it traveled far and wide, especially during a time where even back then, people were traveling globally, given it was kind of sort of the end of World War I. And so millions of people died. You also get these unique social implications that we're well familiar with today, like masking, shutting down schools and daily life in general. And also, interestingly, we existed in a background of turbulent international politics, World War with the Trump presidency, but also domestically, the United States found itself ill-equipped to deal with the pandemic. So the two research questions I'd like to pose are, what were incarcerated people's attitudes towards their healthcare during the influenza pandemic? And how can their lived experiences inform the practice of prison medicine in COVID and beyond? So our model is going to be a historical prison called the Eastern State Penitentiary, which is no longer operational, but it was quite famous back in the day for its policies of prison reform. It's still standing in Philadelphia, but as a tourist attraction. And what's interesting is that in 1918, the male population was allowed to circulate their own newspaper, which was called the Empire. And I actually found this through a Google search. And here's this blog post written by the historians who maintain the Eastern State site. And they talk about how the incarcerated people really just were so grateful for their physician. They gave him honors and awards for carrying them through the pandemic. And so I was really interested in further exploring this doctor-patient relationship. And I was able to get my hands on some digitized copies of the Empire from that year. So let's just start by saying that the prison experienced its major outbreak in the fall. The warden had the good sense to impose an immediate and enduring ban on visitors and in-person gatherings. So this was considered a relative success, even though they did have 2 more cases in December. In total, only about 5% of the incarcerated population got sick. So this is 63 out of over 1,300, more or less. And so out of these 63 cases, there were only 3 recorded flu-related deaths. So the incarcerated people were quite aware of their relative safety compared to the rest of the city. And indeed, in many instances, they do champion their doctor and the warden and other staff in general. But some more careful reading actually suggests that they sort of saw him as a sadist. So this is one passage that describes how the residents pretended to look healthy so that the doctor would no longer have a reason to put a sort of a scope or a tube down their throats. And so they say, we feared to Doc's disgust, we registered normal. So really cynical of his intentions. And so I want to note that we should read this in light of kind of historical context. So eugenics was very much a movement during this time. And in fact, past physicians working for the Eastern State Penitentiary were rather vocal about what they saw as like the hereditary inferiority of, the patient that they called criminals. So really scathing. So what about our primary source itself and sort of like the subjectivity of this newspaper? So ostensibly, it was not censored. There's supposedly a lack of top-down influence, but it's clear nonetheless that the writers really tempered their opinions. So they're saying here, our paper cannot be radical, it must be moderate and so on. And they're showing evidence of intentional messaging to the public. So they admit that they were showing to the world that there is much good and much of the worthy and redeemable in men behind bars. And so there are criticisms of kind of like society or of just kind of how dreary it is to be in prison, but they're quite sparse and they're very vague. And instead, they publish quite prolifically lots of motivational articles on changing yourself for the better, on the virtue of trying to form good relationships with prison officials. And they talk about charity work that they did and how much they wanted to support the war despite not being allowed to serve. And so my conclusion is that incarcerated people during this time felt quite a bit of pressure to embody and portray society's idea of a good citizen. So something like virtue signaling. So this is basically someone who's like hardworking, who's obedient, who cooperates with the authority. But paradoxically, society also seemed to expect them to be fully self-made and self-responsible, sort of in a bootstrapism way, which suggests that incarcerated people could not really rely on the system to help them. And instead, they had to kind of, work on themselves to be better people. And so I present this as a conflict between subjugation to the authority and trying to kind of redefine and preserve your autonomy. And I believe that this explains very well their relationship to the physician. So rather than expressing their dissatisfaction and their mistrust with the doctor, unless it was done in a very subtle or coded way, they ultimately felt compelled to honor him and to celebrate him in the paper. They did try to resist medical procedures that they felt were forced upon them. but notice that they did so in ways that wouldn't directly challenge the authority of the doctor. So for instance, lying about their own health status. So what about COVID-19 today? Almost 100 years later, we see similar themes. Not much seems to have changed. In fact, some things have gotten much worse. So as you can see with Alex and Jaelen's research, which will analyze these themes further in depth and more systematically, you can see kind of from stories published by the Marshall Project of how incarcerated COVID patients kind of overcame their illnesses and sort of how they felt about their healthcare. You see a lot of coercion, feelings of dehumanization as well, and powerlessness against the health system, and not surprisingly, suggesting that they are less motivated to avoid engaging with healthcare. So learning from Eastern State, where can we improve? For one, I believe that trauma-informed care should be a greater, a more, I guess, strongly emphasized in prison health settings. So just really understanding that like people's behavior may stem from the sheer cruelty of just being in prison and be informed by that experience. And what's also really important is patient autonomy. So when you are feeling so disenfranchised, having control and choice is likely to be rather empowering. So really quickly to go over some challenges, we don't have much material to go off of because much of the focus on the time was on the war itself rather than the flu. And what we do have is often masked by humor and sarcasm. So it can be hard to kind of assess the true motives of these writers. And finally, most importantly, this paper in the prison itself was dominated by white men. And so you have a glaring lack of female and minority voices in this prison. So not well representative of today's prison cohort. And so our next steps are really just to kind of write a manuscript to capture a lot of nuances and kind of incorporate the research that we've done on like prison life in general and people's relationships to power in the prison outside of the flu. And I'd like to end here really quickly with some acknowledgements. Thank you so much to my entire team and my peers for all of their feedback and guidance, and to you for your time today. So this has been really fun and enlightening for me.
Thank you, Charlotte. Awesome job. And I think that your maybe birds in the background were agreeing that you did a great job.
Sorry, I meant to kind of shut them in the cage.
Oh, stop. No, it's great. We had even more of an audience, especially on these quiet Zoom days. I am looking for a question right now. Oh, wow. Caroline Sarnoff started her career as a historian at Eastern State. Really interesting. So I'll let some questions roll in, but you know, one thing I just reflect, it's not as much a question, but maybe you can give us some insight. Like, I've seen your project come, you know, to fruition slowly over time. And I think in the beginning, it had a more cursory look at the writings. Like your conclusions have developed dramatically as the summer has gone on. Can you talk us through sort of like how you got there, or what things you've learned about approaches to historical writings from incarcerated people that you would kind of use on your next project if you were to do something, a historical archive project again? How did you start molding and changing the ways you understood these words?
That is so interesting. Because I don't know that I can answer that in a succinct way, because I sort of came in with sort of like, I guess, a negative bias where I was expecting lots of like harsh punishments and really oppression of these incarcerated people. But what I actually found was that Eastern State was, I guess, purportedly, it had like relatively good living conditions. They, for instance, like they really believed in like training people to like have jobs once they were released. They taught people to read and write English if they couldn't, and so on and so forth. But certainly there is like a need, there was like a growing need to kind of also understand that, the picture was not all rosy, as you mentioned. So I think something that was really instrumental to that was my mentor's suggestions, mostly Alana Rosenberg, who really wanted to dive into kind of what was life like at Eastern State. And so if I can just kind of share my screen again, something that I would have loved to talk about, share. For instance, there is a really great secondary analysis on baseball, because that was really like a big facet of social life at Eastern State. And so baseball was something that was kind of like by allowing these incarcerated people to form baseball teams, they did kind of, I guess, reach like what this historian describes as positions of authority, and kind of the ability to exist on like an equal playing field as people who were like not incarcerated that they got to play against, or by prison staff, so on and so forth. But ultimately, a lot of these things were designed to kind of inculcate and indoctrinate incarcerated people. So for example, the middle class really liked baseball over things like football, because it was something that emphasized self-control. It wasn't a violent sport, and it avoided physical emotional excesses. So just things like that really clue you into how, even though Eastern State was like a model of like prison reform and kind of like rehabilitation, it still had its limitations, and kind of saw its people as like in a very patronizing way.
So I'm hearing the real importance of looking at multiple sources from multiple point of views, and really kind of drawing the story up to kind of, fill in the gaps. I think there remains a huge gap in that incarcerated people couldn't really publish what they were thinking, right? And so all of this is in like code language and virtue signaling, like you're saying, and we don't know what they really, other concerns they may have had. So I think there remains a big gap, but I think you've done an awesome job at putting together some picture of what the doctor-patient relationship was like that can inform the future from what you had, from what exists. Thank you so much.
Thank you.
I'm going to keep moving us along, and we'll see if more questions roll in. Awesome job. Next, we have Heather Destiny Konan, who is an undergraduate student at Emory University. We are so happy to have her here with us for the summer. She will be giving a talk entitled The History of Correctional Healthcare and the Law in Texas Prisons and Jails. I think she may have changed the title, so I'm going to let her actually, now that I remember that, I'm going to let her tell us the title. Go ahead, Heather.
Hi guys, I've been having a lot of internet difficulty, so apologies if I cut out later, but can everyone see the screen okay?
Great.
Good, awesome. So yes, I recently narrowed my research topic significantly, and I'm at the stage where I'm really focusing on heat, health, and COVID-19 in Texas state prisons. And I just wanted to acknowledge everyone who's really helped me with this project this summer. Alana, Dr. Thomas, Dr. Puglisi, and like everyone that's been a part of this team. You guys have just really helped me kind of like, just bring it down to something really specific and really important to me. So thank you. So first, just to introduce myself, I'm, as Dr. Puglisi said, I'm from Emory University. I'm a neuroscience major, minor in history, and I'm on the pre-med track. So this is just like such a great opportunity for me because it's really melding my two interests. Of course, I'm a part of the Radx archival research team, and I've always kind of been interested in like the history of medicine. But it wasn't until my freshman year in college that I got to take a class called Madness in America and the intersection of mental health and mass incarceration that I really started to see like how there is this huge field of carceral medicine that doesn't have enough voices talking about it. So again, this was just a great opportunity to really like delve deeper into those interests. So in starting with the background of my project, as some of us may know, in 1976, there was a US Supreme Court case that finally codified medical indifference to incarcerated people in prisons and jails, and kind of said that like any deliberate indifference to medical conditions or medical issues of incarcerated people would violate their 8th Amendment constitutional right. However, in the 20 decades following that Supreme Court case, there was that massive spike in incarceration, what we know as mass incarceration now. And throughout that time, mass incarceration kind of gave way to overcrowding in a lot of prisons, and Texas was not excluded from this sort of overcrowding issue. And in that, there was a contribution to slowed maintenance of a lot of the infrastructure in these prisons. And essentially this led to kind of a breakdown in the like health conditions and the correctional health care system, as there were just too many incarcerated people to kind of care for. And Texas state prisons have also kind of cited that in cutting costs, they aren't able to provide the proper infrastructure now, even if they're aware of the problem. And that kind of leads us to now. Obviously, we are all aware of the pandemic. We know that in 2020, the pandemic kind of really like re-highlighted and reiterated how the lack of proper infrastructure and treatment protocol can really lead to these exacerbated health conditions. And one thing that I thought was really important was that the pandemic also highlighted the perspective of correctional officers and facility staff. And these are voices that I find are often not as explicit when talking about healthcare conditions in prisons and jails. So kind of really narrowing the background of this issue of heat in Texas prisons specifically, I wanted to first show you guys the National Weather Service, their heat index. And this index is kind of just showing like the likelihood of heat-related injuries or illnesses. And basically you have relative humidity on the y-axis and temperature on the x-axis. But I want to bring your attention to the red, which is noted as extreme danger. And if heat indices are in these numbers, you know, you're really at a level where someone could or would have heat stroke or hypothermia or anything kind of related to heat-related injuries. And so then when you look at the document on the right, you can see that this is a log of one of the units in Texas, the Hutchins unit. They logged kind of the air temperature as well as the humidity, and then the resulting heat index at different times during the day. And you can just see I circled two of them. At 9:30 a.m. you have a heat index that's already at 120 degrees versus 11:30 a.m. you're now at 149 degrees plus. And so if you go back to the heat index, that's all in extreme danger. And this is in the morning and right before noon. So this is just really highlighting that like heat in these prisons is not just kind of the average 90-degree day, right? It's a pretty substantial issue. So with that, all of that being said, it kind of led me to this research question. I recently modified this with Dr. Puglisi's help, so I'm also still in the process of like answering and addressing everything, but I'm basically looking at what can be learned from the history of heat stress within Texas prisons throughout the early 2000s, and how can this essentially inform future policies that address COVID-19 in correctional facilities. And in doing that, I'm also kind of implicitly looking at the relationship between the health interests of correctional officers and incarcerated people. And I did say different health interests, but a big part of my project is kind of, I don't want to assume that they're different. So also looking at like where their health interests really converge. And then additionally, how might a history of failure or success in Texas prison regulations inform future advocacy efforts? Just how do people go about self-advocating for themselves, and what's the most effective? So just quickly in looking at my methods, Alana really helped me just kind of break it down. I have my first phase, my second phase, and I'm really in my first phase right now. I'm really exploring all of my different documents and sources and trying to get to that point where I can compile them and then really start examining them, which is phase 2. And at that point, I can start considering the health implications of heat, as well as, like I said, looking at like the continuity and change of the advocacy efforts shown. So then I created this lovely infographic to kind of show everyone my thought process when I was, one, getting at this specific question, because I did really start at this broad stage, but also just in looking at how I came about everything that I'm going to show you later. So first, I kind of found policy about heat in the Texas Wallace PAC unit. And from there, I looked for any organizations that were involved with the Wallace PAC unit and the policy that kind of came out of that unit. And so I've like kind of specified everything on the sides. So yeah, I looked at the Texas Prisons Conditioning Advocacy group, and they had a lot of resources, very specific resources on only things containing air conditioning and heat. So it just goes to show you, like, this issue is so specific but so significant and important in Texas. And then again, just triangulating all the information I have, and then finally looking at like lawsuits, specific cases and lawsuits, and Dr. Thomas really helped me with that through Westlaw. And then finally, I will hopefully be at a point where I could start building my analysis. So in looking at how heat is a health stressor, one, I just wanted to highlight some quotes from, first, the one at the top is from Keith Washington. He is a part of the Incarcerated Workers Organizing Committee. And just the part about him being a chronic seizure patient who had his seizure medication discontinued. Heat has been known to kind of exacerbate a laundry list of conditions. And these are conditions that a lot of incarcerated individuals, unfortunately, do have. Diabetes, sorry, I have a list, but it's a lot of conditions. And because of this, it's kind of pertinent that heat, which is something that can easily be fixed, should be fixed, because these patients, like these incarcerated people, have other conditions that they have to deal with. And then on the bottom, I wanted to highlight that there are also, besides physical health issues, heat really has negative impacts on mental health. So this was from an op-ed from the head of the Texas Correctional Officer Union. And he was just talking about how he saw himself that there was a noticeable increase in like heat intolerance and aggression from different incarcerated people because of the heat. So I just wanted to like highlight that this, at the end of the day, is a health issue first and foremost, not just budgetary or political at the end of the day. So then this was a really big part of my question, and it's a big part of my secondary question, and it's this idea of convergence. So in 2013, after about 5 years of contested lawsuits between the Texas Department of Criminal Justice as well as incarcerated people, there was finally a public statement from the Correctional Officer Union that kind of publicly supported all the lawsuits that had been compiling against the Texas Department of Criminal Justice. And this was huge because you're finally seeing it's not incarcerated person versus correctional officer. It's both of them are being affected by the same issue. So it must be a really, a pretty big issue. So I just wanted to highlight here, this is from the University of Texas, their report on heat in Texas prisons. Essentially in 2012, you had 92 correctional officers who suffered heat-related injuries, 55 additional in the following year. And then you have all these compensation claims from the correctional officers. And it's just an ongoing problem that like finally the union said, okay, this is an issue not just for incarcerated people, but for our officers as well. And I'm going to talk about it in the discussion, but I feel as if that might have helped with policy related to it. So again, this was part of something I wanted to do in my analysis, and that's really creating a timeline. One, to kind of show how long the process is to even get to any sort of policy, but two, to show everything that went into this kind of minuscule policy in the grander scheme of things. So in 2008, you have the first publicly filed lawsuit, Blackman versus Garza, and it was a lawsuit filed against correctional officers for extreme heat in this incarcerated person's cell. But then in 2012, so that case was dismissed, but in 2012, the Fifth Circuit Court of Appeals in Texas actually issued an unpublished ruling, basically saying that exposing prisoners to extreme temperatures is indeed, a violation of their Eighth Amendment. And the following year, that's when you get the public support of correctional officers. And again, that's just to kind of contrast. 2008 lawsuit is against a correctional officer. 2013, correctional officers are now kind of saying, yeah, we agree with the past lawsuits and any lawsuits going forward. Then in 2014, you have the University of Texas, their clinical report on deadly heat. It was very scathing, and it really highlighted, these are the numbers, these are the stats, and it's still going on. And that was also when the Texas Civil Rights Project finally they had a federal class action lawsuit with people from the Wallace PAC unit, which is one of the main affected units in Texas. And then finally, so 2017, the judge ruled for the incarcerated people in the Wallace PAC unit, but it wasn't until 2019 that the Texas State Appropriations Committee even amended the proposed budget that would require Texas Department of Criminal Justice to log the temperatures inside their prisons and jail cells, which is a policy that matters, but you have to think about the amount of people that died, and yet Texas Department of Criminal Justice is still not kind of moving to the part of, okay, let's add air conditioning units inside the prisons, or let's build new facilities inside the prisons. But I just wanted to highlight that policy. And then, so what does this mean in terms of COVID? Because that's a part of my research question. One thing I found that was really, really interesting was in 2017, there was a case that followed another one that dealt with heat and temperature regulation. Again, one of them was in the Wallace PAC unit, but essentially the incarcerated people who the case was filed for, they asked for 3 subclasses to keep people safe from excessive heat. And these classes were general class, heat sensitive subclass, and disability subclass. So the general class, all inmates who are incarcerated in the Wallace PAC unit and are subjected to the Texas Department of Criminal Justice's policy and practice of failing to regulate high indoor heat index temperatures in the housing areas. Then you have the heat sensitive and disability subclass, which is just adding, if you have a chronic health condition that can be exacerbated by heat, then that's a different class. And then finally, disability, that's a different class. And the judge on this case, he mandated these classes, but then you see in 2020 in a separate case against the Texas Department of Criminal Justice, same unit, there was a case related to COVID-19 and the indifference in medical policies and needs there. And in that case, the plaintiffs also asked for an emergency injunction to ensure that not only were the classes that were mandated in the 2017 case were being used for COVID, but that they would add an additional subclass, which is the mobility impaired subclass. And that's just kind of categorizing people who suffer from mobility issues. And in this case, the judge also granted this injunction and certified the additional subclass. But all of this to show that there was a case of heat that kind of set precedent for this other case related to COVID, and really kind of gave this other case the jumping point in terms of these classes. So then in looking at my discussion, obviously I'm still in phase 1 preliminary phases, but some things I could draw from everything I've kind of gathered. One, policy seems like the most effective policies so far are explicit, specific, and repetitive. What I mean by that, when people are complaining that heat is the issue and the Texas Department of Criminal Justice just needs to add an air conditioning unit, the department is able to get away with not adding that air conditioning unit because they can cite, oh, it's going to cost $20 million, right? And then from then on, they can just ignore all of these complaints, versus what I saw, a pattern that I saw was when a proposal was kind of brought forward to the House, the Texas legislator, and it had specific like concrete steps. We need to have phases, maybe 2 of the units have air conditioning, and then the next year 4 of the units have air conditioning, and then the following year 6 of them have air conditioning. That's when the Texas legislator was kind of more willing to even look at the proposal. So that's explicit and specific. And I say repetitive because, like the 2 cases I just showed you, maybe it takes precedent and repeated kind of repeated policy mandates to finally get the policy like implemented and enforced. Obviously, I'm still looking through that, but those are some things I was kind of drawing from all the results that I've looked at so far. And then second point is I've been seeing how like the concerted efforts of correctional officers and incarcerated people is possibly pushing policy reform in the right direction, because you now have these 2 roles that were kind of historically oppositional kind of joining forces. And I'm really curious to just see how that interacts with not just heat and not just COVID, but like all health issues within the correctional network. So that is definitely something I want to look at in the future. And then some challenges I've had and will probably keep having, limited perspective of correctional officers. I haven't been able to find any cases that relate with the correctional officers being the plaintiff, but I'm hopeful that hopefully I can find some more concrete evidence of their opinions about the correctional system. And then also, I just wanted to note that the Wallace-Paxton like federal class action lawsuit, they noted that a lot of the heat stroke deaths were vastly underreported. And so some of the statistics weren't necessarily like completely accurate. And that's a challenge moving forward, depending on what I want to do with all of this research, might be significant or might not be. And then these are just my next steps, really consolidating everything I've shared with you guys, maybe narrowing down to 1 lawsuit and really focusing on that just because it is a lot. And then really considering my secondary questions and beginning analysis. So that's all. And thank you guys for your time. If anyone has any questions.
Heather, thank you so much. I think you've put so much hard work into this, and I know it's still very much a work in progress, but I think it's been really fun to see you go from your initial conceptualization and really bring it to this well-defined question at looking at health stressors like heat and how we can learn from that and find similarities with other things like infectious disease stressors to health. And I'm particularly really excited about you looking at this concept of convergence. So where do interests align? And where do sort of unions and incarcerated people agree, and how does collective action, or does it, lead to different outcomes? And, I'll say that there may be people still on the line, but I know we have colleagues who work in Texas, and none of this is unique to Texas. It's just an example, but who may know even more. And we feel free, anybody working in Texas, to reach out and chime in. I'm opening it up to questions, just looking at the chat. Oh, interesting. Joanna's looking at extreme temps and sleep, which is really interesting.
Heather, I wonder, I think something, and I see also that Alana's offered this in the chat, of what the limits of the law are. And I've seen your work kind of progress through the summer of thinking back, well, there's a Supreme Court case, Estelle v. Gamble, and then certainly things are going to change. And a lot of it is, that when laws are there, so much of it, of course, is really in the implementation and the interpretation and the execution of those laws. And so to me, I mean, I wonder if you could share something about kind of where you've seen this intersection between how the legal remedies are fixes or not, and especially if, this thread on convergence, that do you need all players on deck to really be supporting, or in the work in taxes, is it just that when correctional officers file suit, there's more likelihood that it will be successful and implemented if there's any tension there?
Right. And before I even say anything, I want to really explain that I don't know enough about the legal side, and I'm really just starting to get engaged with that aspect. But from what I've been kind of reading and skimming through legal documents, just seeing essentially seeing how courts break down cases and really break down the issue and codify everything, I do find is really important, because even if what a court rules on, let's say, they rule on something in favor of incarcerated people and kind of asking the Texas Department of Criminal Justice to implement a certain policy, and they can mandate it however many times they want, and still the department is kind of not budging. Even if all of that happens, I think the fact that the courts have established, well, at least we've given a name to all of these issues, we've really broken everything down, and yes, the policy isn't working now, I think people can still learn from that. And obviously, if you have access to all this case law, you can always go back to it and see okay, here's what the courts wanted the department to do then. It didn't work out. What can I use from that? What can I take from that? What were some of the, what were the issues that kind of led to a lack of enforcement of the policy? But as well as what were some of the successes from that court case? Obviously, that's not a remedy, but I do think just the way legal documents and courts kind of go about being so explicit about everything. That was also my whole discussion about the specific and explicit. I think that has implications for how policy can be made in the future, and kind of tracking the continuity and change of that. And then I wasn't sure about your second question. It was about the convergence aspect.
Yeah, I was just mostly, just in maybe you're still really early about, because again, it goes to this place where I kind of think if only a big lawsuit's filed, et cetera. But, if correctional officers are behind the suit, if it's more likely to be successful, if, if what you need is a whole host of people behind a suit, or are there examples within history or within your research that have shown that makes it more successful, or is it not really played out as a factor?
So that was one of the limited perspective that I had with my research, in that I couldn't find concrete cases or documents that really explicitly said, okay, the plaintiff is a correctional officer. I just really had those articles saying they're supporting it. But I do think, and this was something that I think Michelle Jones brought up sometime in the summer, about the idea of looking at the overall correctional community. And that's also including the families of incarcerated people, correctional officers, anyone who can and will be affected by something like heat as an environmental stressor. At the end of the day, it's more beneficial to look at the overall community, because the overall community is being affected. But I personally haven't found anything that's kind of proving oh yeah, they need to work together and that's the only way. But yeah, I'm still early in research, so.
Thank you so much, Heather. I'm excited to continue to work with you on this. And I'm going to stop us there and move along to the next presentation, just for the sake of time. We are thrilled to have Brandon Hudik with us, who is also a Yale Medical School student, who is going to be presenting to us on the experiences of healthcare among people without housing in New Haven, Connecticut. Brandon, all you.
Awesome, thank you. Can everyone see my slides okay? Awesome, yeah. So my presentation and my project this summer is titled Experiences of Healthcare Among People Without Housing in New Haven. I'm colloquially referring to the people you would think of as homeless, but I'm trying not to use that term. I was mentored this summer by Dr. Ben Howe and Alana Rosenberg. And so I'm actually a classmate of Charlotte, second-year med student here at Yale. And I have interests in one day, bringing primary care, something routine that many of us take for granted, to populations that either don't have access to it or are disenfranchised by it, such as the unhoused community. And so New Haven and its unhoused population. So in 2019, a point-in-time study found that New Haven has 503 people homeless, which is a rate of 9.39 per 1,000 residents. And of those homeless, 100 were unsheltered, 370 in emergency shelters, and the rest in transitional housing. So this homeless or unhoused population is traditionally what people define as people living without stable housing on the streets or in hotels and motels. And oftentimes they lack access to basic means of maintaining health, again, that we take for granted, such as clothing, access to phones, access to healthy, affordable food, transportation, basic hygienic stuff such as toilets and showers. And compared to housed counterparts, the unhoused population is more likely to become chronically ill, hospitalized, and die at a younger age. And some of these causes of excess mortality include infections, mental illness, cardiovascular disease, hypertension, et cetera. And oftentimes this population is forced to prioritize more proximal needs, such as food and shelter for the night over their healthcare issues. Plus, there's this lack of access to preventative care. And oftentimes this exacerbates their medical conditions and also leads to more acute care usage, such as emergency rooms. And so the literature describes many dynamics within the healthcare system that act as either exclusionary or inclusionary when it comes to the population that is chronically unhoused. And some of the exclusionary dynamics that the literature covers are, a lack of accessibility, such as difficult to make clinic times and locations, access to transportation, finances, and the cost of healthcare services and insurance coverage, as well as having a place to store your medication. Like this culture of stigma, a lot of people in this population encounter when they walk, through the healthcare doors. Care fragmentation, these people have to be vulnerable with their provider oftentimes, and to have provider turnover and people you have to retell your story to can be disenfranchising, and as well as, red tape on the administrative side of things. But it also describes some of the inclusionary dynamics within healthcare, and some of these include harm reduction models, outreach programs, trauma-informed care training for providers. And the VA hospital has an HPAC program, which is like a one-stop shop care model, which provides housing, social services, addiction, as well as having team members with experiences of being unhoused on the team. And however, a lot of these experiences, the experiences of these dynamics by the population without housing are not well characterized in the literature. And that was sort of the impetus for this research, was to see how people are experiencing these dynamics. And so that leads me to my qualitative research questions. Number one, how do people without housing experience healthcare interactions, specifically regarding the various dynamics that exist? And what are their responses to these experiences, and what consequences may these responses have on their health and future care? And ultimately, the aim is to highlight considerations for healthcare providers in New Haven and more broadly, so that we may better serve those who are unhoused. And so there's potential from the information in this project to gain insight into some additional research questions, as the data of the study I'm going to be using uniquely follows participants over time, including into the pandemic era. Specifically, are there any longitudinal trends in people's experiences and responses to healthcare dynamics? Do these trends persist if and when they're no longer housed, and how has the COVID-19 pandemic modified people's experiences and or responses? These are just potential additional questions I might be able to start to answer with this research. So in terms of methods, this study and this project has been a secondary analysis of qualitative interviews from the Justice, Housing, and Health Study, or Just House. And that was a study designed to study the intersection of criminal justice system, housing, and health with a focus on sexual health and HIV risk. And the study recruited 400 low-income New Haven residents, 200 of which were recently incarcerated. And these participants took a baseline study in the fall, or survey in the fall of 2017, and follow-ups every 6 months. Of those individuals, 54 of them participated in qualitative interviews every 6 months for a total of 5 interviews. And they were interviewed by 3 team members, and the same interviewer interviewed the same participant across waves. And each interview lasted an average of 54 minutes, and an interview guide was used to cover a range of topics with some built-in flexibility on the things they covered. Some of these topics include housing, criminal justice involvement, the economic situation, sexual relationships, and health, amongst others. So of the 54 participants interviewed, 36 identified as being homeless, which they responded on the survey question as being homeless, living in a homeless shelter or in a hotel motel, or having been homeless in the last 6 months at some point during the study. And so this summer, to begin, I read complete transcripts from different participants who were interviewed of the 36 that identified as being homeless. And I read their complete transcripts, and I began developing a draft code book with the Just House team's input. And then I extracted those transcripts of the homeless individuals from in vivo that were index code under physical health. And I applied and revised the code book I developed using Deduce, and I will proceed to analyze some of the themes that will come out. And so I used the physical health index code mainly because I wanted to limit the analysis more to traditional physician-patient encounters, and that code specifically seemed to capture those encounters better than some of the other codes. And so also to examine longitudinal trends, I will also reference matrices that the Just House team put together that summarize each participant's situation over time. And so here's some of the codebook examples of exclusionary dynamics that I was coding for in healthcare interactions. This is just a small subset of the codes I use, but you can see I code for paternalistic interactions, punitive interactions, cold servicing, and I coded first for dynamics, and then also I coded some of people's responses to these dynamics. For example, here, avoidance or self-removal from services, generalizing their experience of services to other healthcare interactions. So after finishing the coding process, I've begun the process of reviewing excerpts and pulling out themes. So I have a few examples to show you where I think the data is headed, albeit this is far from exhaustive. This first example will probably come as no surprise to anyone, but one of the themes that I see is emerging is that healthcare systems are commonly set up in a way that their unhoused patients perceive as discriminatory and unwelcoming. And so this excerpt is of an unhoused patient explaining how they were treated in the ER when seeking a place to sleep for the night. They weren't even allowed in the door once they were recognized as being someone just looking for a place to sleep. And so I think the implications of this is it might set up, this setup can distance the provider from their patient in terms of accountability, as if they never even have the interaction because of this red tape and administrative blocks, as well as distance the patient from the provider in terms of just trust and engagement with the healthcare system. And this is also a place where there's missed opportunities to engage with this vulnerable population that often already mistrusts the healthcare settings. And this specific patient, their response to this dynamic was to actually make up a medical condition just to get inside. And I coded that as a survival coping mechanism. Another theme that I pulled out is that providers who are assumptive of the needs of their unhoused patient may be perceived as paternalistic and untrustworthy. And so this excerpt I pulled out from the interview is an example of an unhoused patient whose doctor seems assumptive about their needs based on their risk factors. assuming that they want STD checks and an AIDS test and vitamin D levels taken. And instead of hearing what the patient actually says, their biggest concern is their weight loss that they're experiencing. And in turn, the patient expresses mistrust and frustration with their provider. But there are also some good themes that are coming out. So this theme, patients who are unhoused often appreciate the convenience, flexibility, and provider continuity when it comes to their healthcare. So these are excerpts from 2 different unhoused patients describing their provider coming to them, being flexible and having rapport and continuity with them. And logically, this can help facilitate engagement and trust amongst this population. I think a caveat with COVID is that some things have become more convenient. Some of the participants have described this, like with telehealth and some of the leniency around appointment times, but other things have become more inconvenient, such as a lot of this population interact with providers and things at places such as soup kitchens, which with COVID, they're no longer really places of gathering. And so that point of contact has been a little bit more difficult. And that's something I'm going to explore further as I go. And so going forward, I want to consider continue consolidating different themes from these codes I've been applying and analyzing them. And ultimately, I do want to develop this into my medical school thesis and potentially a publication someday. And I just wanted to say thank you again to Alana and Ben, who have been incredibly kind, and their mentorship has been great this summer, as well as everyone at SEICHE for their input on our presentations all summer. But that's all I have.
Brandon, awesome job. Thank you so much. Let me see what questions we have coming in. While I look at that, I also want to acknowledge that Brandon got the 2021 Social Justice Scholars Award from research produced by medical students in the summer. And congrats again, Brandon. That was, we're really excited for you. Okay, questions coming in. Can you tell us a little bit about, maybe you can go back a couple slides, but your kind of focus on physical health?
Yeah, so the Just House team applied index codes to all the interviews, and one of the index codes was physical health, but there were also codes for substance use and mental health that I didn't use when I pulled out my study subset, and that's mainly just because I feel like the physical health code better captured when people were interacting with a physician or a nurse practitioner, or some of the other codes they were talking more about experiences at different rehab programs and substance use programs, which I think are important, but I did want to limit this project to some degree. And I do think people on the Just House team are doing important projects around mental health and substance use separately. And obviously those things still come up within the patient-physician encounter, but they're less of a direct focus, I think, for this project.
Got it. It's interesting though, right? Like, I mean, we segment these things even in our health centers, right? There's the behavioral health department and the internal medicine department. And yet, what we often hear from patients is they kind of want everything to be dealt with together, right? It's a false dichotomy to say that there's 2 different types of health and different people should address them each. And I wonder what we could learn about people who interact with health in a different way sometimes, but about how they really want to receive holistic or whole person healthcare.
Brandon, I wonder also, so this work is so grounded in, New Haven, which is near and dear, and with your work with Alana and Ben, have you started thinking about presenting this work back into policymakers, trying to think about, what's this going to do to inform housing policy in New Haven or Yale New Haven Hospital at large, and even the creation of a kind of space for young housing insecure individuals, the plans for opening a shelter space for them?
Yeah, I think I've really I've really just started to like go back and look at all the codes that I've applied this summer and like pull out some of these recurring themes. And so I think I'm just at the beginning process of that. But I do think that is an important thing to think about in the future.
I'm seeing that Nadine asked basically that same question here in the Q&A. And another fun thing, Brandon, could be Nadine is a member of our lab who you may have met before, but does a lot of work around housing in New Haven, even outside of work. And it may be interesting to link up and have Nadine help you think through too, how you may use some of this data locally right here in our city to change things or improve them. And Alana suggests presenting it back to the Community Advisory Board as well. Great, so to be mindful of our time, we're right at 3. We're so grateful to all of you. I have to say this has been the most students we've ever mentored at once as a lab, and it has been so joyful. I didn't get to really advertise it, but probably the most fun for me was the real collective learning. So we met all together and all helped each other on these presentations and defining questions and really learning how to give a scientific talk. And I learned so much from you all. I know that we all did on our end and are so grateful for you joining and pushing science forward. And we look forward to thinking of ways to bring this back to our patients. Thank you all. Thank you for everyone who joined, and have a great day. A big round of applause for all of our student researchers. Thank you, guys.